All right, we've hit 12:01. We're going to go ahead and get started. Hello, my name is Polo Camacho. I'm the program manager for health ethics and community engagement at the Center for Practical Bioethics in Kansas City, Missouri. As many of you joining us today know, there have been significant changes to the TPOPP POLST Clinical Guide and Form, with help from TPOPP POLST advocates in the bi-state area, including many of those joining us today. The center has made significant changes and finalized changes to the TPOPP POLST Clinical Guide. These changes include comparisons between the TPOPP form and other Kansas, Missouri forms, an updated frequently asked questions section, an updated section by section breakdown of the form. The TPOPP POLST form was also modified to be continuous and more consistent with the National POLST form. The webinar today is intended for current TPOPP POLST advocates who want to learn more about these changes. The webinar will also be helpful for healthcare providers interested in implementing the TPOPP POLST program in their healthcare organizations. So joining us today are staff from the Center for Practical Bioethics, John Carney, our CEO, Ashley Glass, and myself. As well as Dr. Jessica Kalender-Rich, Dr. Alex Gamble, and Dr. Charles Crecelius. Thank you so much for helping us with this presentation today, y'all. So a little bit of housekeeping. We are going to be fielding questions as the presentation goes on. So if you have any questions as we're going through the clinical guide and form, please be sure to ask those in the chat. And our Ashley Glass, our center staff, will be fielding those questions and bringing those up as they arise. So without further ado, let's go ahead and get started because we have a lot to cover. So today we're just going to go over the objectives for today's presentation. We're going to discuss updates on changes to the TPOPP POLST initiative. We're going to review the form. We're going to review the TPOPP POLST clinical guide, and also we're going to be hopefully at the very end gathering feedback from you all on how we can move this initiative forward, and then ultimately address questions. And as I mentioned earlier, if you have any questions during the presentation, feel free to raise those questions in the chat and we'll address those. So diving right into the form, the biggest changes we made to the form were the color of the form. So those of you that are familiar with previous iterations of the form used to be completely pink. Now we've changed it from a white form with a pink border around the edge. And that was prompted primarily by issues that came up with copying the form, sending the form out to various individuals, faxing the form, etc. So we felt that this would make it easier for transportability. And since the initiative is the whole point is transportability, we thought that would make it easy. It makes it easier on copying. Right now, as it stands, forms must be ordered in bulk for tracking. And at the center, we really sort of take ownership over the tracking. We ensure that the form is being implemented properly across the bi-state area, Kansas and Missouri, and we sort of gather information about its utilization across different areas and different geographies. We've also included the National POLST logo, and this leads into a really important sort of point that I want to mention, that we've now gone from discussing the program, we used to characterize it as a TPOPP program. Now we're now characterizing it as the TPOPP POLST program, and this is due to the fact that many individuals, many healthcare providers, et cetera, were wondering prior to us making this change whether TPOPP was in any way, shape, or form related to the POLST. And so we're hoping that by calling it the TPOPP POLST program, we can eliminate that confusion and people can see that we're actually a part of the National POLST program. I'll go ahead and move on to the next slide. We've also clarified a lot of language, first to be consistent with the National POLST guidelines and the National POLST form. For example, treatment is used throughout the document. The goal sections are broader. They cover sections B and C, and nutrition section allows for no decision as yet. I don't know if you wanted to say anything more about these points here, John, but most of the language was the changes to the language were to be less pejorative. We're sort of veering away from things like goals of care language and focusing more on the patient preferences and patient values. But I want to see if John has anything more to say.
In the past, the goals section, which is now a separate section D, has additional orders in it. The goals are still affiliated in section B in terms of using common language, but in the past, we only really had one place where you could do additional orders. And so that new section D is going to help clarify that can be in any of those addressing any of those issues in B and C that we'd want to do. And then, as you mentioned, in section C, we also made an option, because sometimes when a document is initially executed, the family hasn't had a serious discussion about nutrition long-term or temporary, but it is something obviously that's going to be maybe later on. So we wanted to go ahead and have a complete form so that it could say it's not been addressed as yet. So that is a new addition related to that section. We'll cover that when the doctors go through it.
Perfect. Thank you so much, John. The reverse side expands information from side one. It includes additional supportive information about advanced care planning, something that we're going to talk about here shortly. It includes a section for emergency contact information, hospice enrollment if applicable, uniform language for support persons. So we have included a section in the document that spells out or create space for people to include information about anybody that assisted them with the form. That could be, a social worker, that can be, clergy, et cetera. So we've included a section in there as well. And as we mentioned earlier, really the changes that were made to the form were changes that were to make it more consistent and cohere with the National POLST form recommendations. And we can say a little bit more about that writ large here shortly. So we're going to dive into the changes to the TPOPP POLST Clinical Guide. This is probably the artifact that underwent the most changes. So we have a new table of contents, and for just really quickly, something that I want to mention before we dive into the changes in the clinical guide is that we are going to be selling through the Center for Practical Bioethics. We're going to be selling single copies of the form for $10 a piece. We're also going to be selling $10 bundles for $45, and we're going to be selling 25 bundles for $100. And so that's sort of where things stand right now, but we're hoping to get y'all's feedback on whether you think that's appropriate, whether you think that's okay. But right now, that's sort of where we are. So if anybody has any comments, questions about that, again, single copies are going to be $10 a piece. 10 bundles are going to be $45, 25 bundles are going to be $100. So if anybody has any feedback on that, please feel free to share that in the chat. Also, we're going to have this the clinical guide available digitally for free. So those of you, and we do encourage you all to, for those who are, especially those of you that are thinking about implementing the TPOPP POLST program for the first time, we really do encourage you to download the clinical guide and reach out to us for a copy of the clinical guide, because really that goes over the history, the development of the TPOPP program, how the form works, how to implement it, frequently asked questions, that sort of thing. So we really encourage those watching today to, for those of you that are new to the TPOPP POLST program, to check out the form. So now diving into changes, we've included a new table of content with jump links. The resources as I mentioned just now, are available via digitally and through hard copy. And again, there's discounts the more you order. The contents include greater clarity and more consistent language. For example, terms like interventions and aggressive treatments have been stricken. There's ACP resources, general advanced care planning resources in the document for training and support from Ariadne Labs, Vital Talk, CAPC, and Caring Conversations. And Caring Conversations is the center's own approach, or the sort of center's methodology for advanced care planning, which we can say more about. And then also we have evidence-based references and an updated bibliography page at the very end. So those are the changes that we made to the form. And so if anybody has any questions about, the clinical guide. So if anybody has any questions regarding that, please let us know. So now we're going to dive in to the actual TPOPP POLST clinical guide, and we're going to offer from here on in sort of like a perspective on the development of the TPOPP program, its history, and also the sort of the section by section breakdown of each aspect of the form. So really, TPOPP POLST is a program that it's best understood as a part of a larger process. Something that we like to talk about or a distinction that we like to make at the center is the distinction between advanced care planning as a process versus the artifacts that assist and that help support advanced care planning. And again, as sort of a refresher reminder, advanced care planning is really a process wherein a patient identifies and documents their preferences with regards to their, a future state wherein perhaps they lack decision-making capacity. That's sort of the first artery of advanced care planning, the general artery of advanced care planning. The second artery would be the appointment of an agent. And this would be someone whose surrogate decision-making powers would be enacted in the event that the patient loses decision-making capacity. So having said that, really the TPOPP POLST program is situated in that process. And what it does is it helps elevate patient preferences into a medical order set. And the POLST program is part of a national program that utilizes a community-based approach. And it's really grounded in the belief that individuals have the right to make their own healthcare decisions and that they also have a right to share decision making. It's designed to improve quality of care for those living with serious illness and or medical frailty, which, prior we, used to emphasize the serious illness part of, as a sort of, who qualifies to fill out the form, those with serious illness. But we have also since we're now discussing medical frailty as being a qualifier there. And we achieve this by establishing communication between the TPOPP POLST program achieves this by establishing communication between the patient resident and also the recognized decision maker and healthcare professionals, ensuring informed medical decision making. So really writ large, the TPOPP POLST program supports the use of a form, a medical order set that reflects patient preferences and is also a part of this larger process, this advanced care planning process. And it's sponsored by the Center for Practical Bioethics and also TPOPP advocates and bi-state collaborators. I don't know, John, did you want to say anything more here?
Just a little bit of history. So in 2009, the center began the process kind of in the Kansas City area with about 25 different people that thought it was important for us to address the issues of out-of-hospital DNRs. And so that process was kind of already established within the community. Within a year or so, we said we were very interested in kind of taking POLST and integrating it into the Kansas City region. That then expanded at the request of the National POLST office to do it statewide, and they knew that we were on both sides of the line here, so they said we're going to ask you to do it for Kansas and Missouri, and we said yes. And so we became the first bi-state, and really I think only still bi-state program in the country. And Polo said earlier that we really rely on the National POLST document, or the National POLST program. They do research. We've had a number of research articles published over the course of the last few years related to how POLST can actually help facilitate actual delivery of care for goal concordant care for people who are seriously ill. So a lot of the changes that he's already identified that we've incorporated have come from the research that that has been conducted nationally, and then a big group of people who have worked on standards and the goals of the program to integrate across states throughout the nation. So this affiliation with the National POLST is very important to us. I want to kind of bring Alex into the discussion here too, because I think the continuity of care across settings is really important. And I know he was very instrumental in getting work started in Rolla, Missouri, when he kind of within the Phelps County Medical Center really helped get this going countywide. And if Alex, if you'd say a few words about kind of how the transportability and also the integration across settings is really important in terms of POLST.
Absolutely. I think as Polo mentioned, right, when we talk about TPOPP POLST, we're talking about a document. We're going to do a really deep drill down today into the document and its updates itself, but it also represents a conversation between patients and their providers, which we're going to talk more about, and which, again, pointing back to Ariadne Labs and Vital Talk, there's a lot of really good skills-based training to help with that conversation if we feel uncomfortable or have some gaps. But it's also this process. And for that process to be effective, to be able to accurately convey patients' preferences for treatment across settings, people in every setting have to be familiar and able to recognize this document and translate that into action where they are, because again, the document carries the weight of a physician's order, so it is actionable by EMS. Our experience in Rolla was really starting from scratch, recognizing that we had these existing relationships from our hospital to the outpatient clinics to long-term care, home care settings, and then vitally the EMS crews that were transporting patients from one setting to another, bringing them in from home to hospital. having a document that's conveying the patient's preferences for care, particularly in an emergency, right? Even life-threatening emergencies, means everybody understanding what this document is and investing in creating processes for the utilization of that document, for transporting it effectively. A single piece of paper in an emergency can quickly be a casualty of that emergency. And so really making sure everybody understands, hey, this pink piece of paper is really important and is able to direct care at every point in care, but we have to understand what it is and be able to integrate that. And so really having clarity at our level about who are our partners, what is their familiarity with this, do they have clear processes and procedures in place? Those are all really crucial. And so one thing that I saw in my experience with that coalition is that that's an ongoing effort. So even where we see, hey, in our house, in our clinic, in our hospital, in our setting, we have a good process. The question remains, do our partners have a good process? Do they feel comfortable? And I think there's always opportunities within our community coalitions to be sort of outreaching and supporting that. It's really something that we all have a stake in, just as we all have a stake in engaging with our patients and their stakeholders in these conversations. But really looking at, do we have a robust process for this? Are we able to capture this information when it comes to us? And are we able to pass the information that we gather in our conversations with patients on to the next point of contact, wherever that may be?
Awesome. Thank you so much, Alex. So now what we're going to do is we're going to dive into the TPOPP program, the program development goals and core elements. And here I'm really going to lean on John and Alex to walk us through the development, the goals, et cetera. So take it away, y'all.
Yeah. So I think we pretty much covered the first part, that it's actually TPOPP POLST. We're affiliated with the national organization, have been now for close to 12, 13 years. The idea is to communicate the individual's patient's preferences for treatments, especially for those living with advanced illness and frailty, by providing a current set of medical orders. So those things are going to change over time, but they're to be honored across all healthcare settings. And finally, it's designed really for use by all providers, including first responders. I think that's important, as Alex has already said, in acute, post-acute, institutional, long-term care settings, and also in community-based settings. So home health agencies and hospices as well, in making sure that we continue to honor, even if there's maybe an alarm goes off, or that we've got a medical injury that needs to be tended to. We don't want to overtreat somebody who's already been very clear about what they do or do not want. So I'll punt to Alex on the primary objective in terms of the goal of POLST overall.
Yeah, so I think as I touched on, as Polo touched on, and again, as I think is crucial for us to keep coming back to, right? What is the heart of this document and this process, right? It's really about trying to improve our ability to achieve goal concordant care, right? But what does that mean? It means engaging with our patients to make sure they're well informed about the nature of their illnesses, about what their situation is, about what the future is likely to hold, including possible or likely complications of those illnesses as we understand them, right? We talk about prognosis, not just in terms of expectations of time, but the progression of their illness. And based on that improved understanding, finding out from them what are their goals for their care. Importantly, as we progress through our life cycle, as we progress with a serious illness, we often find that, number one, there are more treatments that might be available to us, but also how effective those treatments might be will change as well. And those have bearing on what patients are up for. And so it's really about engaging in this process that's occurring over time, that we have opportunities to contribute to at different points in time, whether we're seeing a patient in clinic and seeing signs that their illness may be progressing, whether we're seeing them in a hospital setting where they're in the midst of an acute crisis, right, where there's opportunities to inform them about what this means for their illness and what the future is likely to look like, and ascertain from them, what does that mean for their goals? Again, as we inform people about things like what the likelihood of success is with CPR for somebody with an advancing or serious illness, that may have dramatic impacts on what their preferences are for those things. So as we engage in that process of conversation, what we want is to really capture our patients' preferences so that when a crisis emerges, we don't have to try to have a really charged conversation with a patient who may not be able to participate in that, or their family who may feel very distressed. So it's taking some of that psychological, that emotional pressure out of that conversation by having it upstream and ensuring that we're engaging in good education to really figure out how does that impact their goals. We can come on to the next slide. So what are the core elements here? Again, we're going to tunnel down more deeply into some of these as the presentation goes on. First is recognizing that this form, we're trying to capture their goals for people with advanced chronic progressive disease, clinical frailty, or terminal conditions. So again, we're not thinking about this as a form that's really appropriate for everyone, but certainly for people with advancing illness. How do we make sense of this? Well, again, as we progress with our illnesses, that has dramatic impacts for what the likelihood of success is for something like CPR, for what kinds of treatments may benefit us, for how well we're going to be able to recover to how we were before. Again, thinking here about functional prognosis. These are the things that are affecting our patients' quality of life. And it's that sense of what quality of life is acceptable to them or what trade-offs they'd be willing to make to extend their life at a given quality that really informs the choices that they're making over time. So we'll talk more about patient selection and who it's appropriate for, but principally it's understanding this is for people as they're progressing with serious illnesses, or where we're able to make more meaningful prognostic statements about what the future is likely to look like for them, especially with regard to their functional status or quality of life, these things that really weigh on people's assessment of what they're up for or where they might want to start placing some boundaries. It can be used to express any patient's preference. So these forms can be used to affirm someone's preference to undergo all available treatments that might extend or prolong life. There are personal, religious, other considerations that go into how people make these decisions. And so again, this form is not about limiting care. It's about providing goal concordant care, whether it's affirming someone's preference for treatment or establishing where they want to establish some boundaries. It provides explicit direction about resuscitation status. This is often the critical question, right? Someone's down on the ground, EMS is called to show up. What we want to know is if they find you pulseless, do you want to be resuscitated or not? If you have a pulse and that question isn't there, this form is also going to go into, well, what are your preferences up to that point? So it's going that extra step of not just addressing code status, but if I'm here in agonal breathing or respiratory distress, am I okay with being intubated? So what we find is when we really engage people in these conversations, as they're well informed about how their medical issues may really weigh on what these likely outcomes are going to be, going down these paths of resuscitation, intubation, and so forth, they may want to place boundaries in different places. The form really allows for a more granular look at how do their goals and preferences need to be translated into specific care trajectories. It includes directions about other treatments that they may or may not select. Again, we'll go through the form in detail going forward. Accompanies them to and from all settings. And that's really the crucial piece here. The idea is that this pink bordered piece of paper is going to follow me wherever I go. I may have a wonderful conversation with the palliative care team in the hospital about my preferences and the boundaries in my care. And as soon as I set foot out into the parking lot, how is that information going to follow me? TPOPP is meant to be a bridge to close those gaps. It's based on their current medical condition. So unlike an advanced directive, we're not thinking about some future hypothetical state. We're saying, what do I want for my care right now if a crisis would occur in this moment or in the next moment? And again, as it goes with us from site to site, it should be updated periodically. I may get information at my next oncologist appointment that bears dramatically on the preferences that I had on my last TPOPP. So being sure, again, that it's traveling with me and it's capturing this ongoing conversation that all of my care providers have a stake in, and that my goals as they change, that the form is updated to reflect that. So that's really the core and the heart of the form itself, but we'll dig more deeply into it as we go forward.
Awesome. We're going to go ahead and dive into the differences between, ACP documents and, the TPOPP form itself. So here, John, I'll lean on you for this section here.
And I don't want to spend a lot of time here, but I think everybody on the call knows there's a difference between advanced care planning documents and medical order sets. And that's really what this is doing, is that obviously advanced care planning is for every adult. We need to have them. We need to name an agent. We need to do all those things. But this is a very different kind of conversation, a much deeper conversation. That's what the links are to the left. Those are live. So if you want to use this slide deck later for your own training, there's actually scripts that are available through Ariadne Labs Serious Illness Care Planning. Vital Talk is a resource now that's available for free. They used to charge for it, but that's now been underwritten by a foundation. All of those resources to the left are live, and they would help you in your own training, your own implementation at your local level. And there's great resources that we don't need to be reinventing. You guys just need to make sure that you're making them accessible to your staff and others in the work. And so I don't know, Alex, if you want to say anything about the medical order side of this document, but basically this is just saying, please make sure that you understand that advanced care planning and medical orders are two different things.
Absolutely. Yeah. Again, I think as we kind of were gesturing at earlier, critically, this form is accompanying a conversation that's a different kind of conversation, right? Where advanced care planning documents, ones we're traditionally thinking about, are just sort of letting people know, hey, these are crucial things that are going to come up for you at some point in the future. You'll need a surrogate decision maker. You may be in an unrecoverable state where we want some direction here about other life-prolonging treatments. This is really an informed conversation focused on patients' current status. What do we understand about their illness? What are they likely to face in the future? And determining based on their preferences and their goals, what are the appropriate orders to put in place for them? And so that's, I think, that critical piece. This isn't just a little bit of education, but really an engaged conversation with our patients and their other crucial stakeholders to really be sure they're clearly informed about their illness, about treatment choices that may come up for them in the future, and we're well informed about what that means for their preferences so we can document that in an effective way.
Wonderful. And now we're going to dive into who should fill out a TPOPP POLST form. So we've sort of touched on this earlier already. We noted that those who are sort of qualified for filling out or enacting or beginning a conversation about the TPOPP form, whether it's appropriate for them or those with serious illness or with medical frailty. And here I'm going to go ahead and lean on Jessica for her knowledge and expertise on this. Jessica, what are your thoughts on those who qualify or those who should be thinking about, approaching their medical providers about TPOPP POLST?
Yeah, a TPOPP POLST form, I think, carries a lot of information, and anybody who has information that should be passed along regarding their goals and hopes for their care in the setting of medical frailty or a life-limiting illness, they should have that form filled out. So it's really for somebody who wants all the stuff done because they want to be sure that people know. It's also for somebody who wants to choose which life-sustaining treatments they would want, or even somebody who wants to avoid all of those life-sustaining treatments and really focus on comfort, right? So it can function as a place for those persons that have a chronic illness or a terminal illness, or even just kind of just progressive decline without any really known exact reason. Those people can really use that form. And I also will add, it's really important for people to have these discussions. It's really important to have these forms, and it's very helpful for those in a long-term care or other community dwelling setting, because in those settings, there's often a lot of staff around and maybe less family around. And so those forms can be really critical in telling EMS and other providers what is going on in that really urgent moment.
Awesome. Thank you so much, Jessica. Now what we're going to do is we're taking, as we mentioned earlier, a deep dive into sections A through E. So each of these sections is divided into section A, cardiopulmonary resuscitation, section B, initial treatment orders. We'll say more about that. Medically administered nutrition, a section for additional orders, and then finally a section that details information with individuals that may have helped the patient sign or execute or, inform the TPOPP POLST document. So we're going to dive right into section A, and here I'm going to hand it off to Dr. Crecelius. Charles, is there anything you would like to say about section A and CPR?
Yeah, section A is probably the simplest part of this form. It is a yes, no answer only, which is what healthcare providers tend to like. Attempting CPR, the word attempting is right because it's often not successful, but some people still want it done. I would note CPR means not only shocking your heart, cardiac resuscitation, but also cardiopulmonary intubation. And when you select no resuscitation or CPR, you're selecting to have your heart not shocked, to not have medicines put in your vein to try and restart it. And you're also not wanting intubation for that purpose. There are people who are approaching death, not at death, that still have a pulse. Those people would still be intubated when they say attempt. Even do not attempt resuscitation. It needs to be clarified with the individual to some extent. They need to realize this means we're not going to intubate you. That can be in later sections stipulated that I want intubation under these select circumstances. I personally don't like that as a medical provider. Tends to make things a bit gray. We do tend to push people towards BiPAP, CPAP, non-invasive ventilation, whenever possible. You will probably find a few people that are going to be demanding about intubation for non-CPR situations. Please make sure they understand that it's not always desirable, that BiPAP CPAP can do just as well in later versions. Hospitals across the United States pretty well have this standardized. Wherever you go, in a hospital, in a nurse home, people do understand, for the most part, CPR. They get a little confused sometimes when they're still have a pulse. Officially, CPR, this section relates to when you have no pulse, when you are basically dead. The other phrase we use is allow a natural death when talking to families. That if you if you want to allow a natural death, you would choose do not attempt CPR. That is goal concordant care.
And now we'll
So just be careful about the intubation section when explaining it to people. Though you're referring here only to the point in which their heart is stopped. There is a rare person with a pneumonia that they do end up intubating after discussion.
Awesome. Thank you so much, Charles. And now I'm going to lean on Charles and Jessica for sections B through D. So section B is initial treatment orders. What are y'all's thoughts, and how would you all characterize this section?
Jessica,
You want me to
Go ahead
kick
first.
it off? Okay.
Yeah.
So, I think, to take what Dr. Crecelius said just a minute ago, right? So that really is defining if a person, like if they're dead, what should we do, right? If they're pulseless and not breathing. And then section B adds on to that, right? So section B is this place where you say, okay, so what else is really important in this emergent situation? So if a person has chosen to get CPR and to be a full code, totally fine. That person is automatically a full treatment, right? Because we are doing everything we can to help that person and to help that person live longer at that time. But many people would choose to do certain things, right? So the selective treatments is a separate option. That's a person would be comfortable with specific treatments, whether it's specific medications or specific other procedures, whatever that may be. That's the selective piece. And then third, of course, is a comfort-focused option to really focus in on people who are only comfort care, primarily comfort care. Now, what's very critical on this form is this goal statement, because the words full treatment, selective treatment, comfort treatment can be very confusing to a layperson. And frankly, even as a physician, very confusing. I want to know what that means. It's that gray, right? So those goal statements are really meant to help patients and families understand what we're saying when we talk about full, selective, and comfort focused.
Wonderful. Charles, what do you have any thoughts on this section?
Yes, actually, I think selective treatment is probably the most important part of this form to define for people. The full code's fairly easy. I want everything done under any circumstance. And the comfort focused care tends to be in hospice-like patients. But there's a broad swath of people in which CPR has such limited success and potential downsides. Getting through CPR, many people are neurologically impaired with a much worse quality of life, but they don't want the feeling that we're giving up on them. And that's unfortunate sometimes in hospitals and other care settings when they see comfort-focused treatment or even no code. They think, well, they're comfort care, they're the same, and they're not. No CPR does not mean that you're going to not use IV fluids. It's very important to clarify that with people. Many people can get benefit from IV fluids, BiPAP, even selective ICU statements under the right circumstance for short periods. You're trying to avoid it, but you're not negating it altogether. But this helps with that feeling of loss or abandonment by providers that people sometimes get when we really don't get to goal concordant care. I realize I'm not a good candidate for CPR. It's probably not going to help me, but please define those things that meet my goals. And many times selective interventions are very appropriate medically, clinically, and psychosocially for the person.
I just want to highlight something that you said. because I think it's really important to say. A person can be DNR or allow natural death in section A, but they can still be full treatment or selective treatment or comfort focused, right? But they can still be full treatment in section B, which really means we would do everything we could up to the point of if that person's body passed away, that's when we would not initiate CPR. So I think that's an important thing to highlight.
Yeah, and it also bears mentioning, and pairing this information with what Jessica noted, if in section A full treatments or CPR is enacted, that would have implications for section B. You would elect for full treatments in section B. So kind of mirroring that really quick. Section
I
C.
think, Paulo, that's a really important point. In the narrative section of the clinical guide, there is significant text on how this needs to make sure to be described to the families to make sure that they understand. So what Jessica was saying about the goals is really important, but there's also instructions to the clinician to say, if the patient chooses, if the representative chooses CPR in number 1, it is inconsistent within the document not to choose full treatment in section B. So those things that's what the clinical guide is there for, to help making sure that that consistency is there, and even some suggestions in terms of how to have that conversation to clarify those goal statements.
Yeah, and as again, we reiterate, and conversely, if the patient elects for do not resuscitate in section A, that does not entail that they necessarily want comfort-focused treatments in section B. They may want selective treatments, full treatments, etc. So that is also that bears mentioning. So now we're in section C, and this is medically administered nutrition. Jessica, Charles, how would you characterize this section? What are the key takeaways here?
Why don't you kick it off this time?
Okay. Yes, this can be a tricky section for religious and other reasons. This form no longer requires you to say just overtly, I don't want any food. They give you various choices. Providing the tube feeding, a trial period is very helpful for some people. And the last one, not discussed or no decision made, is perfectly legitimate if a person is uncomfortable talking about this for religious or personal reasons. This section is more for chronic disease and not the acute state. So in terms of the immediate impact of this, it's normally not something I have to fix today. But we want it there because it can be a subacute problem that has to be addressed. And for many people, it is an important goal of their care to define when they would want artificially administered nutrition, when they would not. So we find many people actually sort of like that trial period. But it does give you more options than we previously had in the section.
And I'll point out that the guide goes through some data around persons with perhaps late stage cancers or late stage dementias or other kind of specific diagnoses to sort of pull in some information that can be used when having these discussions. And that I think can be really helpful. And then I'll just highlight it's really important when discussing this that we share that, of course, we're going to continue to offer oral feedings, oral fluids. This is not about that. And it says that, of course, on the form, but I find that it's a critical thing to point out to families and patients, as this can be a really challenging topic to discuss for some people.
Correct. I would add that this whole form has nothing to do with euthanasia. That occasionally is brought up. Quite the opposite. It's defining what people want. This form in no way allows euthanasia, or is intended to invoke that. So that subject comes up, please discuss with people. We are not providing euthanasia under any circumstance whatsoever. This is about your personal wishes as you let us know your goals of care so we can provide goal concordant care. Now, we can't provide goal concordant care for somebody asking for euthanasia. That would be the caveat.
It's also important to note that there are significant resources that have been added and updated to the bibliography, especially related to this. So there's a lot of research that has been done over the last 20 years on this topic. And I think it's very helpful. And the links within the document, if you get electronically, are live, and you can actually go to the documents themselves and the research. And they're also listed, if you get it in print form, for your clinicians and others to inform themselves and to suggest to families reading material that they may need as they progress in their illness in terms of the effectiveness of feeding tubes in certain disease states.
Wonderful. Thank you so much, y'all. Now we're going to delve into section D. And this is where I'm really going to lean on Charles and Jessica yet again. But before we do that, something that we often say at the center is that the TPOPP POLST form really goes beyond other medical order sets, and that it captures the nuances, attempts to capture the nuances of what a patient wants, what a patient prefers in the event that they're seriously ill. As we noted earlier on, this can sort of be understood. The form, the program can be understood as sort of where advanced care planning is sort of the spectrum. The serious illness care planning is sort of at the end of the spectrum, where we're really trying to capture what's happening now in this moment as the patient is dealing with serious illness or medical frailty. And so really this section D really attempts to capture more of the nuances of what the patient wants. And here I'll lean on Jessica and Charles. What are the key takeaways here? How do we describe this section and how can it be utilized?
I describe this section as the place you can put the stuff that doesn't fit anywhere else. Right? Like you can put in, I've had patients say, I'm willing to try that ventilator for 5 days because every time I'm on it, it takes 5 days to get better. But if it takes more than 5 days, then I want you to talk to my family about comfort. Or I don't want a tracheostomy. If it gets that bad, that's my cutoff line. Or there's tons of different things out there, right? Somebody who's gotten chronic blood transfusions may say, this is something I really want to continue versus this is something, as long as it's not hurting me versus something, this is a time I'd want to stop that. This is that like open box where you can add the nuances of that patient's goals so that they are heard even if and when they cannot speak.
Yeah, I'd agree entirely, Jessica. It's definitely a good way to expand on B and C when it's needed, and it often will be. The time-limited trials is especially important and often clinically appropriate. Blood products, as mentioned, can be very appropriate or inappropriate, and people may want to put limits on this. I had one person with recurrent diverticular bleed, multiple other problems. He basically said, if I don't respond to 3 units of blood, stop. That's a little unusual. But you'll find people have things they really want to express to feel they're being heard that need to go here. For the most part, D is enacted in the hospital, but not in the emergency room or ICU setting. And it's the finesse of it all. It's not, this section doesn't really relate to the CPR at all. You note this, there's no additional orders for section A, and there should not be. It only relates then to, all right, now what? How do I meet my needs? What can you do for me? I had one person fill this out once that basically said after her granddaughter was married, she didn't want anything done. That was tricky. We actually told her she really preferably should fill out a new TPOPP form in that case when you have a major change. So be a little careful what you put in D. It really shouldn't be any revocation of the whole process dependent here. There should be a direction to reevaluate if this happens. Or I would like these orders reevaluated at a certain time. Some advanced directives allow for latitude of family. If there is a family that whose consideration should be taken at the moment, if they're unable to speak for themselves, that could be put here also. Not the CPR section, but time-limited trials for not only a week, but then perhaps as for a time directed by my physician and family member, Miss So-and-so, for example, would be a legitimate order you could put here. Some people don't want to put an exact time on time trials. They want a consensus at a particular time, and that could be stipulated here. The time and the general time, more importantly, who's to be involved in the discussions.
Wonderful. Thank you.
Yeah,
so
I think, Chuck, that's a really important point too, to reinforce the fact that once the information in D is no longer valid, then a new TPOPP POLST form is initiated. So that it is intent. This is not a one and done document. This is obviously the dynamic of it is really important in terms of being able to make sure that it covers the patient's current condition, however that may be. So those stipulations you put in D may have a very important life cycle within the entire time frame that we're looking. But once they're concluded, a new document needs to be initiated.
So thank you so much, y'all. We're going to move on to section E. And section E is, information about, information and signature. And so here I'll lean on Alex and John to sort of elucidate and characterize this section. What are the key takeaways for this section, y'all?
Yeah, so critically, that we really need to have a physician signature. So right now, and I'll let John speak to kind of what our ongoing efforts in state of Kansas. But critically, we need the signature of both the individual completing the document with their physician and clinician, whether that's the patient or their recognized surrogate. So just clear documentation there, and then signature of the physician as well. We also have documentation here for who this was discussed with specifically. And on the back of the form, which we're going to get to, there'll also be some areas there for documentation for who is involved in the overall conversation, understanding that these conversations are not just going to be between our providers and our patients, but also importantly, their stakeholders are there. A question that often emerged when we were doing implementation in Rolla was, well, what happens if EMS shows up, the form is presented, and there's somebody standing there next to them verbally trying to override the form? And what it really points at is the importance of both these conversations being upstream, but them also including other people that might have a stake in what these decisions are getting made. What we heard from people in the field was these forms are really effective at helping address what's going on in that moment, right? What we're encountering is an emotionally distressed, very understandably emotionally distressed loved one who's having a reaction and being overwhelmed in a moment. What the form did was provided an opportunity to remind them, hey, your loved one here said that in a case like this, this is what they'd want, and that could actually be really effective to getting people through the emotional intensity of that moment. And so again, who is involved in this conversation? That's what we're trying to capture here. You can imagine a situation where that loved one, their name is listed here on the sheet, and we can say, hey, I can see that you were here when they were having this conversation with Dr. Gamble. Do you remember that? And just bringing them back into that space. Our focal point, if the focus of this is honoring our patients' wishes, no matter what they may be, no matter what's going on, that's how we want to sort of help with that. So understanding who is in that conversation and getting that documented here, knowing that might be critical in the moment that this form is being engaged with.
Yeah, so let me talk a little bit about that, the check boxes in the first section of E, and then who signs the document. So the idea is here that you're trying to honor and make sure that we respect the wishes of the patient. So if the patient is capable of signing, giving the instructions, the patient's name goes in there and the patient signs. That's probably step one. It's very likely that over the course of the illness, the patient may not be in a condition when the condition changes for them to make changes to the form. And so somebody else is going to have to step forward. But if there are instructions given, there are already advanced care planning documents in place. We've already had a previous POLST form document already initiated, and we need to continue, then another person can step forward. So there are certain limitations in law in both Kansas and Missouri related to the responsibilities of a guardian. However, a patient representative can sign the form if what they are doing is acknowledging, which is really the only purpose of something other than the patient signing in this first section, that the responsibility of a patient representative or an agent is to concur with the medical order. The form is validated with that signature, either the patient or the patient's representative, whichever one of those that they choose. It is not an instruction from the patient that says, I'm ordering the doctor to do this. That's a different form. Okay, in Kansas, that's a different form. This is a medical order. And all the representative or the patient signature does in section E is to acknowledge that this is consistent with the goals that are expressed by the patient or in the best interest of the patient. So I want to make sure everybody understands that. It's required to be valid, but it is not, you're not ordering it. The doctor signs the order. Okay, so the doctor, I'm going to talk about that now. So in Kansas, PAs, physician assistants, can sign the form, all right? It is possible that within the next year, nurses will also be able to do that. Right now, it is not possible in the state of Kansas for nurses to sign this form. It is limited to doctors and physicians. There is work that was done this last year with the advanced practice nurse law, and we're going to be going back to the legislature, hopefully in January, and updating this so that nurses will be able to do it. But right now, the only clinical persons that can sign this form are either doctors or physician assistants. In the state of Missouri, the limitation right now is just doctors, the only people who can sign it. That doesn't mean that advanced practice nurses can't be involved in participating, which is on the back side of the form. They can be, especially primary care nurses that are in those roles, especially in rural areas, can participate, and they can do that. But right now, the signature of the clinician in the state of Missouri has to be a doctor, and in Kansas must be a doctor or a physician assistant.
I'll cap this with two final points. So House Bill 29799, we get a lot of questions about that bill with regards to APRNs. That only confers authority to execute, to prescribe medication to patients. It does not confer authority to fill out a TPOPP form or a medical order set. And then the other caveat is that nurses can sign, but only under a collaborative practice agreement with a physician. So that's the only sort of condition under which a nurse can currently sign. But as John mentioned, in the state of Kansas, PAs can sign, physicians can sign, APRNs are not yet eligible, and in Missouri, still only physicians can sign. So we're going to go ahead and go through these next few sections rather quickly. We have a few questions in the chat. We're not going to get to them all today, but what we're going to go ahead and do is record a lot of them. Actually, is going to jot them down, and then we're going to send an email follow up with answers to those questions. So for this section, I'm going to lean on Jessica. Advanced directives and emergency contacts. What takeaways would you recommend here for people that are watching?
Yeah, in the interest of time, I'll be a little quick. The key here is that the TPOPP POLST form does not replace the advanced care planning documents. Those documents still exist. They're still really important. They still tell the patient's preferences, perhaps in a slightly different way. And this is the section where you mark off what is the other stuff that exists, and hopefully that you have, right? Their health directive, their advanced directives, same thing, their DPOA for healthcare, their emergency contact, which is really important if the patient moves different place to place, and then all the other people who are helping make that form so that if there's a question, we know who to go back to.
Awesome. Thank you so much, Jessica. And for these next two slides, these are things that can be found inside of the TPOPP clinical guide. So if we don't cover everything today, download the clinical guide. I'm going to include the link to the download here in the chat so you all can see that. But at this point, what we're going to do is I'm going to hand it off to John, and we're just going to briefly go through the comparisons between the Kansas and Missouri forms with the TPOPP POLST form. Oh, you're on mute, John. Sorry.
These next two documents are really an hour-long training, so I'm not going to spend a lot of time on it. They're very important to read. So just to clarify, in Kansas, the existing law for out-of-hospital do not resuscitate directives is a statutory form for the patient, a capacitated patient. There is no other way to fill out a out-of-hospital do not resuscitate directive in the state of Kansas unless the person has capacity. The difference with the TPOPP form is you can have a medical order signed by a doctor that says we don't have to have capacity because the person has already expressed their wishes. So it's very important to understand this has been misused and improperly executed across the state, that there's assumption that the doctor's signature on this particular form is the medical order, and the patient is required. The patient is required to sign this form, but it's also true in the state of Kansas that if the patient says, I have a religious objection to having any kind of resuscitation attempts, they can sign the form without a doctor, and it's still valid. So just make sure you understand that the Kansas out-of-hospital do not resuscitate law is a directive of the patient. It is not a medical order. It is an instruction to a doctor to execute a medical order. So enough said on that. So let's go on to, and we've got all these different sections about how it's different and what the target population is and the settings and all that kind of stuff. So you guys can read all that when you get it, but that is a really important item to cover. On the Missouri side,
Oh, let me see if I can go back. Yep.
sorry. So on the Missouri side, what we have is, we do have the purple form in the state of Missouri. So it is an out-of-hospital do not resuscitate law, but it deals only with the on-off of the CPR. And so we've gotten multiple indications from the State Department of Health and Senior Services over time through the medical, the EMS Bureau and others to say that there is no requirement that the purple form be the only form for out-of-hospital do not resuscitate orders. Okay, there is no requirement that that happen. So you can use in Missouri the TPOPP POLST form. It is current law in the state of Missouri that if you want immunity protection for that, there's some hang up that you have with your provider or somebody says we're only going to do forms that have that. The purple form is going to need to get attached because CPR is the only thing that's covered, and that's the only thing that's going to provide immunity. But it is not required by the state of Missouri Bureau of EMS, Department of Health and Senior Services, for that to be in place. So just so you know, they do recognize this as a standardized medical order and can be used throughout the state of Missouri. And I think with that, I'll let you guys take a look at the documents when you download them. They're part of the guide now. We can have them separately. They're on our resource page. They're provided separately if you want to download them and use them for training in other ways, but they're part of the clinical guide as well.
Yeah, and one thing I'll sort of end with is that the new clinical guide also includes an updated frequently asked questions section, and these are questions that many of us at the center have had to field, and then individuals and various bi-state area, the bi-state area have had to field, and so we've updated the frequently asked question section in light of all of those considerations. And again, I'm going to drop the PDF here in the chat. But if you have any questions, comments, concerns, feedback, or any recommendations about the TPOPP form, the initiative, maybe you saw, the section that we covered earlier today and have further questions on that, please feel free to include those in the chat. What we're going to do is we're going to take all those questions and respond to those via email next week and perhaps within the next 2 weeks or so. But we just want to thank you all for being here and for joining us today. I don't know. Do you all think we have time for one really quick question?
One other point I want to make is the resources on the website now are all updated on the center's website, and the ability to download the document is on the website. The ability to order the document, the not only the form but the clinical guide is on there. And just as I guess a request to all of you, we printed hundreds of these before, the clinical guides to go with it. It's a very important document. And then people just started ordering the forms and they dropped the clinical guide. It is important for everybody to use the clinical guide in the administration and teaching and execution of this document. And so we're going to be we're bundling them in smaller quantities so that you can get them out to people. The electronic version's fine for you to have, but we are trying to make sure that we're going to make them available to you in small quantities at a reasonable price for the clinical guide.
Awesome. Ashley, is there a question in the chat that you think is worth bringing up at this point? We can maybe address one and then respond to the rest later.
Yeah, I think a good, possibly quick question to answer, maybe that we had a question in the chat that says, so the patient representative does not need to be the legal MPOA. Is it more like a witness?
Okay, so you want the advance directive, if there's an instruction in terms of who that is, to be able to sign the document in terms of the power of attorney, the durable power of attorney for healthcare. That's your preferred state. If you have an instruction from the patient, all right, and the patient's already executed a document, and all you're doing is updating it and concurring with the change that's already taken place in the best interest of the patient, a representative can sign the document because you already have an explicit instruction from the patient that the doctor and the patient has already acknowledged. So you're not changing anything. You're just basically stating going forward. It is always preferable to have the durable power of attorney for healthcare sign the document if the patient cannot do that. But in the state of Missouri, the power to make those changes has to actually be executed within the document itself. So you have to be able to do that. So it's always going to be preferable to have the agent, the representative can do it if there's already a previous instruction for that individual and you're just concurring, you're just acknowledging that that person is following an instruction that the doctor's already received and that the patient's already given.
Awesome. Well, thank you all so much for joining us. I just want to thank all of our guests for joining us today and learning about TPOPP. I want to thank our faculty, Jessica Kalender-Rich, John, Alex Gamble. I want to thank Ashley Glass for joining us, Charles Crecelius. I want to thank you all for all of your efforts in moving this initiative forward in the Bi-State area. Please stay tuned for further, workshops and training on the TPOPP program. For those of you that haven't yet added us on Facebook, Twitter, and social media, please follow us where you can receive updates on our advanced care planning initiatives and programming, including TPOPP, POLST Caring Conversations, and everything. So we just want to thank you all, and we will touch base shortly with answers to all of your questions. Thank you so much and have a great day. Bye-bye.
Thank you, Paulo.